Hi, I'm Dr. Becca Kennedy,
And I'm Howard Schubiner.
and this is The Science Behind the Symptoms, where together we will explore the new science of neuroplasticity through a lens of curiosity.
You did that so well, Becca.
Oh, why thank you.
And this is a podcast of the Association for the Treatment of Neuroplastic Symptoms.
And welcome, everybody. Today we have Gigi, and she is going to tell her story, a very interesting um, long story, and we think that this will be helpful for all of you. And so I'm
Did
going to
you
just
did you
invite
say
you.
did you say horrifying story or
Long and horrifying.
horrifying too? Okay. Sorry,
Well,
I couldn't resist.
well, most of the stories that we tell on this
A
at
little
the
bit
beginning
horrifying.
part of them are right.
Yeah.
But I mean, we don't want to spoil anything, but we generally have a good ending at the end. So,
Yeah. Good movie.
but yeah, with that, Gigi, let's open it up to hear your story.
Yeah. Well, first and foremost, thanks so much for having me on. I was so excited to speak with you both. But yeah, going back to the long and horrifying story. Yeah, my story started when I was quite young. Um, the symptoms sort of began when I was around 11. But ultimately, what ended up happening is I received a diagnosis of Ehlers-Danlos, specifically hypermobility Ehlers-Danlos. I always joke and say that this diagnosis at the time wasn't really based on anything other than the fact that the doctors took one look at me and thought, she doesn't look quite right. She's really tall and, very skinny for my height. And they were really concerned that I had a more serious connective tissue disorder called Marfan's, which has more severe cardiovascular implications.
Sure.
So they were very keen to get me genetically tested. But fortunately, when those results came back, everything came back clear. I didn't have Marfan's. And then at that point, it was almost given to me as a diagnosis of exclusion. Now you have Ehlers-Danlos, and we'll put you in the hypermobility bucket.
Mhm.
Now,
Well, you are hypermobile,
oh yeah. Yeah,
right? I
big
mean,
time.
there's some basis for them to say that you're hypermobile, right? I mean,
Totally.
you could do a demonstration if you want.
Absolutely. Well, not only is there a basis, I mean, if you look at me now, I'm 6'1", very slender, and I'm hypermobile almost everywhere. So there is no doubt that I have some form of connective tissue disorder. And the demonstration, I think Howard is hinting at, for people listening, they'll probably be fortunate not to be able to see this, but I can put my thumb right behind my hand, and it was when I showed my rheumatologist that at the time. He said, "Oh, I'm going to take a picture of that." And that's when I first started getting put in medical lectures and then medical textbooks. So I always say that I am quite, I mean, by definition, the textbook example of somebody with
Gigi,
Ehlers-Danlos.
are in medical textbooks?
Yeah, my hand was used as a demonstration as the example of what a Ehlers-Danlos hypermobile hand should look like. So I was used as the reference point. So I am proudly an Ehlers-Danlos ambassador in terms of how we look and how we present.
The card,
But when
right?
Exactly. But when I got this diagnosis, I mean, I was so young, it didn't really mean anything. And I wasn't particularly symptomatic at that time. But what I find very interesting in retrospect is I was told, along with the diagnosis, this puts you at risk in developing a whole bunch of different conditions in your life. And I was told by my doctor, you're more likely to develop POTS. I had no idea what POTS was at that time. You're more
Mm.
likely to develop chronic pain. You're more likely to have digestive issues. You're more likely to have chronic fatigue. And I was sort of listed all of these things. And I think when you're in good health, you can't really imagine that ever not being the case. So I sort of took it with a smile and went off in my everyday life and didn't really think a lot of it. But relatively shortly after, I ended up having an accident where I severed an Achilles tendon. And it was the way that I did it was very shocking. It was actually a far more severe injury than people had initially thought at the time. And I was wheeled in for emergency surgery. And it was not long after that I started to develop my first my first set of symptoms, if you will. So for me, it started off with more POTS type symptoms. I started finding it really difficult to not only stand up, but actually sit up in bed. My heart rate would skyrocket. My
And how
blood
old were
pressure
you at that point?
at that time, when my POTS symptoms started getting bad, was around 14, 15. Yeah. And then it just became progressively worse. I remember my cardiologist once saying to me, he said, I've never measured a blood pressure this low in anyone who's conscious. And I remember thinking, okay, great, I'm excelling at something, but this isn't the thing that I really want to be excelling at. It's never nice to feel like you're at one end of the extreme.
Yeah,
And
absolutely.
And I think that's ultimately what started building this narrative of there being something wrong with me. I'd received this diagnosis at a very young age. Suddenly I was being told that I was, extremely tall for my age, extremely underweight for my age. I now have extremely low blood pressure for my age. It was just everything was building this narrative that I was in some way defective.
Mm-hmm.
Um, but I continued as to live life as normally as I possibly can or could. And I was extremely sort of academically ambitious. In my family, the way that you sort of got respect was by demonstrating your academic worth. And that was the way that I derived a huge amount of my own personal value and sense of self. I
Why not
was
Good thing.
I'm
Good
sure.
thing I never. Good thing I
Familiar.
never had to deal with that. Yeah.
Yeah. So I was working as hard as I possibly could. And in the UK, I went to school in the UK. The education system forces you to pick what you want to be from a very young age. And so I remember as I was revising for exams, I was also in the hospital at the same time because I was so unwell. And
Mm.
there was one moment which it's very difficult to forget, but I was lying in the hospital bed and the doctor said to me, as I was holding up my biology textbook, wanting to be a doctor, because that's ultimately, my aspiration at that time, because I spent so much time in medical systems. The doctor saying to me, Gigi, maybe this just isn't on the cards for you. Maybe you're just going to have to let go of the idea that you're going to be able to take these exams. Um, Ultimately, though, that was the idea of not doing it, I think was actually more overwhelming to me than the idea of doing it. So I sort of pushed forward, carried on, and ultimately got a place at Oxford where I then studied biology. And those years were actually some of the happiest years of my life. But I was really living, like I said before, living life as a series of boom and busts. Sometimes I would be able to function, and then other times I would be completely laid low.
Mm-hmm.
But the diagnoses just continued to accumulate as time went on. So not only did
Laid,
I
laid low with what? What symptoms were you?
the POT symptoms were really, really difficult to handle. I then started to develop
You
chronic
mean
pain,
dizziness? Dizziness with standing?
dizziness. Along with the POTS, I had some very strange neuropathic sensations. So I always talk about a sensation of it felt like an egg cracking on my head. And
Hmm.
I would feel this cracking sensation on my head, and then it would almost feel like yolk trickling
My
down
God.
my head. And when it would reach, when I say it, when it would feel like the yolk was reaching my eyes, I would start to feel like I was going to pass out. And then I
Wow.
would sort of tilt forward and feel like I was going to faint. And that would then trigger almost a panic attack because your body is trying to raise your blood pressure. So you have this whole adrenaline release, and then you get into this cycle, and before you know it, you're having a panic attack whilst also thinking that you're going to faint. So I would have lots of episodes of that.
Hmm. And what did
I
your
had
doctors say when? What did your doctors say when you told them this story about the egg? I mean, they must have been like so, I don't know, bewildered or
Used.
confused. Yeah.
completely confused, totally bewildered. And the only thing that they could point to was MS, because so many of my symptoms at that time were nerve related. So it wasn't just the egg cracking sensation. I would also come to them and say, it feels like somebody's pouring warm water over my foot. And they
Hmm.
would say,
Oh, wow.
okay, all right. And then I had, I absolutely had the symptoms of what they call the MS hug, where I felt like my chest was being constricted in a band. It felt
Hmm.
like I couldn't get a breath in. So a lot of my symptoms really mirrored what you'd find in MS. So I had a medical team who, despite not understanding what was going on, they were very empathetic. And their answer was to send me for more and more and more and more tests. So I had, I don't know how many brain MRIs and MRIs all over my body, and, you know, blood tests and the works, ultrasounds, and everything would invariably come back clear, apart from, you know, the normal human abnormalities. And at that point, I was always just told, this is your Ehlers-Danlos. You know, we've always told you that you're more likely to get these conditions. Guess what? These conditions are magically now happening. And this is just something that, unfortunately, you're going to have to learn how to live with. And
So
I think
you were
that's
being told at this point that because you had this genetic condition of Ehlers-Danlos and the hypermobility, that was the reason for the POTS or for all of these other symptoms that they couldn't explain otherwise.
absolutely. I was told that it was due to the joint laxity that I was getting dizzy when I stood up. But the one thing that never made sense to me, I mean, it really never made sense to
I
me,
didn't
because
get
I
it.
thought, well, I was more hypermobile when I was younger. I'm becoming
Yeah.
progressively less hypermobile, and yet my
Yeah,
symptoms are getting worse. So how does that
yeah,
align? Or I
right.
would have a friend of mine who was, you know, a gymnast who could touch
Yes.
her toes far more effectively than I could personally touch my toes, and she was running around completely symptom free with nothing at all. So there was such glaring exceptions to this rule that was being given to me. It never really fit, but it was the only thing that I had. And when you feel like it's the only thing that you have, that's just what you have to go with. But
Yeah.
you touched on it there where you said this genetic condition. You were told that it's because of this genetic condition. And I think that's what's so toxic about the Ehlers-Danlos diagnosis, is when you view something as genetic, you view it as lifelong. You know, and
Yeah.
that massively
Right.
influences your perception of what you feel is possible for you, even though you may not have had your symptoms from birth. So if it were truly genetic, you know, it doesn't actually make sense how they can only develop it much
Yeah.
later on in life.
And you were
Right.
trained as a scientist. Your degree in biology is training you as a scientist. And what you're just saying now is scientific thinking, scientific reasoning. You know, why does
Mhm.
my friend, she's hypermobile, has no symptoms? Why am I, you know, I was more hypermobile when I was 11 than when I was 15 or 18. Why are the
Mhm.
symptoms worse? You know,
Mhm.
it doesn't make sense medically, scientifically. And you figured that out, but you were in this environment where everyone was telling you, you know, that you're doomed, basically.
Absolutely. And you know, I think sometimes the issue that we can face is, even when you have an amazingly empathetic doctor, the fact that they're empathetic means that they want to give you an answer, because they themselves feel like a failure if they cannot provide you with something.
Yeah,
So I think very well meaning doctors, because of their empathy, feel forced to put labels on people that may initially provide short term relief, because we feel like, finally, I have an answer, and we have this cathartic release of it all makes sense now. But that's very short lived. And then the reality of what the diagnosis really means begins to sink in. And the long term implications of an Ehlers-Danlos hypermobility diagnosis, the long term implications of that are significantly worse than if we were never given that diagnosis in the first place.
Right. Yeah.
yeah,
Mhm.
exactly.
And, you know, as a primary care doctor myself for decades, I tried for a while, I have to say, even saying, "I'm believe you, I'm sorry. I don't know. I don't know why this is happening. I don't know how to help you." You know, after we've tried everything. And that answer is it's very difficult to give. And I mean, obviously, it feels terrible on both sides. Even, you know, I would find that patients would come back over and over, and saying that over and over was not acceptable also. And so and it is. So there's the empathy, and there's also sort of expectations, or there, you know, it's like, what do you do with this? And I think that yeah, we're all always looking for a diagnosis. And I think that's such a good point, is is giving that diagnosis more helpful for someone or less helpful?
Totally. And I was very lucky to have a wonderful GP, and she said a very similar thing to you, where she said, "I can't tell you why this is happening," because she actually refused to attribute it to the Ehlers-Danlos.
Oh,
And she said, I can't tell you why this is happening to you, but what I can tell you is you will be okay and it will
Yeah.
get better."
that's
And
awesome.
I look back at that in hindsight and think that is probably the best thing that any doctor could have said to me. But at the same time, I think I was probably very similar to your patients, where that didn't resonate when I was suffering in real time. And
Understandable.
exactly. And guess what? In the same way as your patients, I mean, I was visiting her daily. She was like a second mum to me. I would genuinely book the doctor's appointment for the following day. And I'd say, "I'll see you tomorrow." And we'll just chat about it again and try and figure out what's going on. I mean, bless her. She probably saw my name in the calendar and thought, "Oh my God, here she is again." Um,
But
but I,
the thing that doctors can do is be validating. They can say, "I believe you."
yes,
Right.
it,
That is so important, that I believe you, that I understand. I don't understand what you're going through because I can't imagine it, but I can see that you're suffering. I can see that you're in pain. I can see that you have all these symptoms that are real. And
absolutely.
that's critical. And I'm guessing that she was able to do that for you.
Absolutely. I am so forever grateful for the support that she provided. I think in terms of to sort of answer the question of how can we give a diagnosis and have it not turn into something toxic, I think something that I'm very interested in terms of where I would love to see Ehlers-Danlos research go is I, I don't think my personal opinion on this is there is no significant evidence that hypermobility is the cause of the symptoms that we go through. But is there a chance that people with Ehlers-Danlos are more predisposed to certain personality traits? Are we more likely to be hypersensitive individuals? Are we more likely to have brains that find it difficult to filter out information? You know, those are things that might make us more likely to develop neuroplastic conditions. And that might provide the answer for why people who have a similar stature to me, why we are more likely to develop these things. Just because we're more likely to develop them does not mean that we have to deal with them for the rest of our life. And this is, you know, going to the spoiler alert in terms of where I am now in my life. I have absolutely no symptoms at all. No pot symptoms, no chronic pain. I really don't have anything. And I haven't had anything for years and years and years and years. I truly consider myself a normal, healthy human being who happens to be highly hypermobile and have Ehlers-Danlos.
And you
You
can
know,
still do party tricks with your thumb.
exactly. Do party tricks and then get kicked out of the party because,
I must
yeah,
admit, when I saw you do that, I was a little bit
nauseous.
yes, exactly.
Yeah, yeah.
Exactly.
It's one of those things. To me, Ehlers-Danlos is the way that I view it is like a fun fact. Genuinely, it's nothing more than that to me. It's a fun fact.
Yeah,
Whereas for
yeah, I
many
think.
people receiving that diagnosis is, like I said, this is the explanation for why I will suffer forever. And it
Mhm.
really doesn't have to be that way.
Yeah,
And
that makes sense.
we've seen so many people who are stuck in that view that is unchanging, and nothing you say will change that, because they are so fearful. They're living in fear every time they move, that they're going to dislocate a joint or dislocate a rib, or
Mhm.
they feel like their bodies are like glass, very
Yeah.
thin glass that's so breakable, and it's so heartbreaking to see that. But what
Mhm.
you
Yeah.
had was interesting, that you had two things happen. One, they told you these are the kinds of things you might expect or you will expect. And then you had an accident,
Mm. Yes.
right? And then the
Yes.
accident was traumatic and it was painful and you had needed surgery for it. And that, I would guess, was a trigger for your brain to go into danger mode.
100%. I think before that point, unless you have something like that happen to you, you suddenly can't imagine being healthy and then suddenly being in an emergency situation. And it's only after going through that, I remember one of the orthopedic surgeons said to me, "You're really lucky to be alive." And that to me was really incredibly jarring, because I was actually laughing on the way to the hospital. I had no idea how serious it was. I was saying, "Oh, I'm going to say I was bitten by a shark." And then I, show up and I'm put into emergency surgery, and I was told it was far more serious than I thought it was. And I think it was that disconnect where, when that doctor said that to me, the way that my unconscious processed that is, you don't know when you're in danger or not.
Yeah, right.
You don't know when you're okay or not. And so the
Yeah.
safest response was then to automatically assume that everything was now
Yeah.
dangerous and everything had the potential to be life-threatening. So there
Mhm.
was that. And then there was the emotional fallout from that. So I was on crutches for a very long period of time, nearly a year. And my school considered me a hazard. So I wasn't allowed to go walk down the hallways on my crutches at the same time as the other kids, because they were scared that I was going to trip everybody else up. So there was a huge amount of social isolation that
Oh my God.
happened from that. So not only had I gone through that as a trauma, I then wasn't able to spend time with friends. I couldn't socialize with anybody. I was, physically segregated from people. And that then became when you're a teenager and when this is all happening as well, that's a huge emotional trigger for you.
My
So
gosh.
combine that with exams and life stresses and family dynamics that, are all very normal. It just became the perfect storm for my brain to find it easier and easier and easier to need to produce a warning signal,
Yeah.
and then there starts that chronic symptom cycle where, when you start having them and your brain just practices producing them again and again and again, the symptoms in and of themselves become a bit of a habit. It's not just, are you overwhelmed? There's also the habit element of it. And so I from that moment on, I was just in a chronic habit of producing
Yeah.
symptoms of all
Yeah.
various kinds.
Yeah. Wow. And your brain just scanning for danger and then just interpreting all these different things as danger. What were some of the other symptoms that you ended up having?
So alongside the POTS and alongside the neuropathic symptoms, I had widespread chronic pain. So that was more fibromyalgia type pain. My knees often felt like I had the flu, that type of fluey, achy sensation. I would get ocular migraines, get migraines generally. I developed joint pain. I developed pain in my elbows. I had excruciating rib pain and chest pain. The chest pain is very classic. That's the feeling of an elephant on your chest, and I would get these stabbing sensations. But the rib pain, um, I I thought my rib was dislocated again, all fitting this narrative of Ehlers-Danlos, and I would actually dislocate my rib to try and put it back in place.
Oh my
Oh,
God.
So,
geez.
so I remember going to see the doctor, and he was like, what are you doing there? And I was like, I'm trying to put it back, because that was how intense the pain experience was. My family described me as the princess and the pea, because I started stacking mattress on mattress on mattress on mattress to try
Mm.
and make it soft enough for me to lie on. On top of that, I developed fatigue symptoms. There was one year on Christmas Day that I, again, find very easy to remember. My family were going on a walk, and
Wow.
I just couldn't keep up. It was like walking through, I know this is an English phrase, but it was like walking through treacle, walking through golden syrup. It felt like the weight of the world was against
Mhm.
me. There was so much air resistance. I couldn't put one foot in front of another, and I could just see my family walking into the distance, and I just couldn't keep up. And then, actually not super long after, my mum had her own health emergency, and my mum in my whole health journey had been my biggest advocate, my biggest emotional support. She had guided me through some of the toughest moments. And when she had her own health emergency, it completely destabilized me, because she was the
Mhm.
one pillar of support that I could rely on.
Yeah.
And it wasn't immediately after, but several months after that, I started developing the first sensations of what then became my IC diagnosis. So it was increased urination, which then rapidly escalated into horrific pain.
And IC is interstitial cystitis.
Correct,
Mhm.
interstitial cystitis. And that, you know, took a life of its own. And within, honestly, the space of a couple of weeks, I was bedbound from that pain, and I went from urologist to urologist trying to figure out what was going on. And again, I was told multiple things, but the one thing that everybody kept coming back to was it's your Ehlers-Danlos. Although interestingly enough, I was starting a write-up of my case, and I went back to my old urology notes, and I noticed something that I'd never realized before, that I'd even said to the doctor, and the urologist had written, Gigi commented on the fact that she has had a stressful couple of months.
Oh.
And at the time, I would have said that, you know, as almost small talk. I wouldn't have paid any attention to that, but it's so interesting looking back on those notes now and seeing that written there, because I obviously see it in a completely new light.
This is where we definitely got to the horrifying part. And,
Yeah.
you know, I don't know how you survived. I mean, I don't know how that list of sensations and symptoms just seems so overwhelming. I don't know how you made it day by day even.
Well, you know, it's funny that you of all people say that, Howard, because it's a slightly long-winded story of how I reached your book, and I'll mention it quickly. My mum found a podcast that was talking about, you know, people's recovery from neuroplastic symptoms, and she absolutely bought into the idea and said everyone who recovers from these things sounds like you. I listened to it, was highly offended, thought that she was telling me my symptoms were in my head, which of course that is not what is meant by this. The symptoms are real, and anyone who says otherwise doesn't understand what's going on. But it planted the seed of maybe there's another option here. And because I was desperate, I had done absolutely everything else that I could. This was really the only thing that I could try and take seriously. And I remember coming across an interview you had done, Howard, at some point. I can't remember what it was, but in that interview, your book was mentioned, and I thought, right, I'm going to read that. That was like my number one thing that I was going to give a go. And what's so amazing is the fact that the list was so long had been the thing that had made me feel so broken. But in some of the opening pages of your book, you listed almost everything I had ever been diagnosed with. And it was the fact that your list was so long, and it was the fact that it included almost everything that I had ever been diagnosed with. That was the earliest, most convincing piece of evidence that existed to me at that time that there had to be some substance to this. Because I thought to myself, what are the chances of somebody who doesn't know that I exist, who is writing this book for the general public, what are the chances of them writing everything that I have been diagnosed with? Statistically, that's incredibly improbable, unless there is some truth to it. And so it was the fact that the list was so long and so horrifying that actually made me listen in the end.
Mm.
Yeah, I mean, that's what I was commenting about, the egg cracking and the, your brain is very creative.
It is.
Very creative. But when you see that, when you see a symptom that's so, I don't know how to describe it other than bizarre, so weird, that no doctor's ever seen that, it doesn't exist, that again, that becomes the evidence that only the brain can do something that is so odd and, weird
Absolutely.
like
And what's so funny is, when I had that egg cracking sensation, I hadn't come across anyone who'd gone through that. And what is so funny is, of all the symptoms that I mentioned, one of the most common emails I get when people are inquiring and working with me is, I have the egg cracking too. It was at that moment that I knew you got it, because you also know the egg cracking. And I thought, there we go. Sometimes it's the weirdest things that stand out to people the most, because those are the things that we can actually relate to, because we've never heard anyone else go through that experience.
My
Yeah.
goodness.
Yeah. And Gigi, did you ever actually dislocate joints? I mean, apart from the on purpose rib?
Yes. So I would very frequently dislocate things. I remember one time I trapped my finger in the hinge of a door, and which was not particularly pleasant. And for any other human being, that would have been a guaranteed break of their finger. Whereas my finger just, came out, dislocated, went back in, and all I had was a little scratch to, and obviously a lot of pain because I dislocated my finger, but that was it. And my knees would regularly sort of, I don't actually know the anatomy of how this is possible, but my knees would sort of come out of their socket a little bit. So every time I would lift my knee up, I would actually only be able to lift it up a tiny bit, and then it would start to dislocate, and then I'd have to lower my knee again, sort of reset it, and then it would be okay.
Do you still have that? Does that still
Yeah,
happen? Okay.
it does occasionally. Yeah.
Sensation.
Yeah, yeah.
And does that hurt? When that happens, does that hurt?
Yeah, it does hurt. It does. It's subluxing or dislocations, they hurt.
Yeah, right?
They're not particularly pleasant experiences. But
Yes, right.
when you zoom out and you look at the Ehlers-Danlos experience as a whole, dislocations make up probably, and again, this is a generalization, but anywhere between maybe 1% to 5% of an Ehlers-Danlos experience. The majority reason of the reasons of why people go to see doctors in the first place, it's very rarely because they're dislocating themselves all the time.
Yeah.
It's much more likely to be as a result of the neuroplastic conditions that they're experiencing, and then they get given the EDS as the diagnosis. So
Mhm.
I'm not saying for one second that learning about this work is going to stop the dislocations from happening. That's
Right.
something real and physical and structural that's
Yeah.
going on,
Yep.
and
Yep.
absolutely I can dislocate something, but that experience is such a small part of my overall health journey that I
Mhm.
wouldn't even categorize it as something that influences my life in a meaningful way.
And after that happens, how long does the pain last, generally speaking?
A very short period of time. I mean, I'm talking
Like maybe
minutes.
oh,
No, I mean, honestly,
oh,
minutes. I mean, it
oh,
could be half an hour, or max an
oh.
hour. If it's a genuinely bad dislocation, yeah, okay, we might have it for a day or two,
Mm.
um, but
Mhm.
no longer than
Yeah.
that.
Interesting. Yeah.
And
Mhm.
how did you get better, and how long did that take?
Okay, so the question of how long it takes is one that I'm incredibly annoying to interview, because it's the one question that I actually refuse to answer, and the reason I
I
refuse
support
to.
that. I support that, just
I'm
FYI.
so glad I
Oh, great.
asked.
Yeah. The only reason why I refuse to answer it is because I strongly believe that it can provide no benefit to anybody. The reason why is if somebody gets better faster than me, they don't care. They don't care how
Right.
long it took me to get better, because they've got better faster. So great. The only time that piece of information is registered is if people feel like they're not matching a specific timeline, and then it
Right.
becomes a source of overwhelm in and of itself. It becomes a reason to doubt in our own recovery journey.
Yeah.
So
Very,
the
very well
thing
said.
the thing that matters more than anything is the fact that I got better. One thing I will say is it was not overnight. So I never want people to interpret that as she's
Good.
not saying because she miraculously got better incredibly quickly. It actually wasn't like that at all. But aside from that, the details actually fundamentally do not matter. I'm completely symptom free now. In terms of how I got better,
Yeah, let's ask that.
That's
Becca, why don't you ask that question?
Remember that for next time, Howard. Write that one down.
No,
Okay.
Howard said it. No, in terms of how I got better, that also is a pretty anticlimactic answer. The reason why is because I don't think that there was one tool or technique that somebody needs to apply vigorously every single day to get better. And I think often the way that I explain this is if you're really viewing yourself through the lens of being healthy, no one who is viewing themselves through the lens of being healthy forces themselves to do something every single day. Instead, the healthiest mindset that you could possibly have is to check in with yourself. That's the one practice that has remained consistent for me when I was symptomatic and now post being symptomatic. It's the check-in. How am I doing? How am I actually feeling? I often use a university example a lot because I was very lucky to have some of the most amazing lecturers in the world. And I also had some of the most terrible lecturers in the world. And I was kind of interested by the distinction, what makes a lecturer great and what makes a lecturer awful. And one of the obvious differences to me was that the lecturer who was amazing was often highly engaged in the person that they were speaking with. They would ask questions. They would see if that person had understood and view it through a lens of or a lack of judgment. It was more of a conversation, a dialogue, rather than somebody just dictating something. Whereas the lecturers who were less good didn't give two hoots if you understood. They were just speaking, letting it all out. And I realized that I was being the bad lecturer to myself. I was telling myself what I should be doing, how I should be feeling, what my viewpoints should be, without actually taking the time to ask, but do I resonate with anything that I'm telling myself? So
amazing.
there are so many different tools that exist out there. There are amazing tools of, I love emotional awareness and expression therapy, being given the opportunity to just let it out, to rage, to view, to not view that part of you through a lens of shame, to know that that part of you is just as valid as the part of you that has learnt the social norms, and to give that part of you the opportunity to express itself. I love that. But do I always need to rage? Do I always need to let it out? No, because sometimes I've raged enough. Sometimes I've actually got the catharsis that I need from raging. And actually, if I listen to myself, it's, I want to distract myself now. I want to let this go now. And so rather than focusing on the how, the what, the action, instead, I try and focus on the why am I doing that? What's the intention behind it?
Yeah, because a lot of
Amazing.
times we talk about the need to fix something, but if you're not broken, you don't really need fixing. You need
Completely.
living. Like I don't go to the gym to fix something. I go just to be healthy because it's fun, right? And what I do. And I think I really, really appreciate how you're, how you're framing this.
Yeah. It's, I think almost another way of explaining it is often if you tell somebody to just live, they'll say, okay, Gigi has told me to live. So what would I do? I would go out, I would go for a walk, I would do this. But they're living through the lens of recovery. Whereas we're not trying to get people to live to recover. We're trying to get people to live because you have permission to live. It's safe for you to live. You don't have to do it through the lens of a health journey. And it's such a subtle distinction because if you look at it on the surface, the action is the same. The person is going for the walk or the person is cooking dinner. But yet the why can influence whether somebody experiences symptom relief, because when we're doing it to recover, we then have that outcome dependence. How did this impact my symptom experience? Did this make it better or not? And if it didn't result in a change, then it's maybe I'm missing something. Maybe I didn't get to a root emotion or a core experience. It starts to provide more overwhelm rather than helping us to let go. Whereas when we live for the sake of living, we can never get it wrong, right? There's no, it's not tethered to your symptom experience. right? And so because it's not tethered to your symptom experience, you're just doing it. You're just embracing it, enjoying it. And sometimes you might not be enjoying it because guess what? We all go to coffee with a friend and think like, I'm not sure that was the best coffee of my life, but that's okay because that's part of being human. It's not, it's not something that's going to have a terrible impact on a recovery journey.
I
Oh
saw
my gosh,
I
Gigi,
saw a teenager. Oh, go ahead. Go ahead, Ben.
I was just saying, I love that so much that we can't do it wrong. And it's about how are we showing up for ourselves is such a huge part of it. I like to say there are no bad decisions. It either goes in the way that we want or what lessons can we learn from it. And I think it really encapsulates that. Although my best friend, who also has a teenage son, says to me, no, Becca, there are bad decisions.
And
I
I would
saw
go back and say, no, there are no bad decisions. Because as you said, it's that difference between the growth mindset and the fixed mindset. This fixed mindset is I messed up, I made a mistake. The stakes are really high.
Yeah,
And when we view things through there are bad decisions, we can then get decision paralysis because when those stakes are really high and we never want to make a mistake, life becomes infinitely more stressful. Whereas
yeah,
if we say, I can make a decision that may not benefit me at all, right, in real time, but
yeah,
it will benefit me in the long run because I'll learn the reasons why it didn't benefit me. And that will
exactly.
reduce the probability of me doing that again in the future. You haven't got it wrong. You're on an optimization journey. And that's exactly what life is. It's just an
Exactly.
optimization journey.
Yeah,
And,
yeah,
there's no defined endpoint.
yeah,
yeah,
exactly.
I saw this teenager who's a fantastic singer dancer. She had auditions coming up for these major shows that she wanted to do, and she had back pain, and the doctor said, well, you can either go ahead with your auditions or shut it down and try to recover. But you go ahead with pain, but you can do your dancing and singing, but you'll have to deal with the repercussions, which is a horrible thing to tell her, right? And it
I
turned out she
just
had neuroplastic pain. And I said, no, you can dance with joy. You need to do your auditions with love in your heart and with joy. And that's going to get you better.
this is something that I find very interesting. It's almost the distinction between law and medicine. I think in law there's this innocent until proven otherwise. Whereas in medicine, I think often what we see is you're broken until proven otherwise. It's the complete reverse. And it really needs to be flipped on its head. There should be an assumption of you are fine until it's proven otherwise. And then we'll deal with it. And then we'll understand exactly why it is. But preempting somebody's future discomfort or suggesting to somebody that they might develop some pain condition or whatever it might be in the case of
Yeah.
your patient who she was told she was going to be in pain after, that is actively doing harm
Mhm,
because of
mhm,
predictive coding. Our
Right.
symptom experience is just our brain's expectation of how we should feel. And
mhm,
you are altering that human's expectation of how they might feel. So, I think doctors have to be very, very careful with their words. And even when that doctor may have been saying it out of compassion, out of concern for what they might be doing, we don't need to preempt those types of things because you are increasing the probability of them actually happening.
For sure. That's what
I
happened
think
to
that
you.
Yeah,
yeah, I think
exactly.
that's such a good point, and I think as doctors, we're sort of trained that we're supposed to prepare people. It's on us if they get sick later and we didn't warn them. That's sort of, kind of in our ethos, and so, yeah, I've seen that so much is that someone's in an accident or they have an injury or whatever it is, and they're given information that, "Oh, well, in 10 years, just wait, and you're gonna get XYZ symptoms," and that happens a lot.
Yeah, it's
Shall we talk about the science of EDS?
Oh, sure.
let's do it.
Yeah, let's do
Where
Yeah,
do you want to begin?
it.
I know there's a lot. Well, one issue about the science, a question I had for you also is that so Ehlers-Danlos syndrome is a genetic disorder, and most of the variants, and there's how many, 13, 15,
13,
with that
13, I think.
we can show on a blood test there are genetic changes that you can see on a blood test. but the hypermobility variant, we have not found the genetic variant for that one. So it sounds like you didn't have the genetic changes on the blood test.
So I did have some genetic changes that are correlated with connective tissue disorders. So there is actually
Oh.
one gene associated, it's a recessive gene associated with blindness, and
Oh.
that's been correlated with certain connective tissue disorders. Um, so I really truly have no doubt that I have a connective tissue disorder. I've got slightly stretchy skin, although I'm not that specific
Mm.
variant, but I've definitely got softer skin than most. You know, I have no doubt that I have some form of collagen mutation. I think
Mhm.
part of the issue um, that underlies all form of EDS research is the diagnostic criteria for EDS is extremely poor. So you're lumping together a bunch of people who fundamentally do not have the same underlying genetic problem. So when you try and identify one in a population of people who actually all have completely different things going on, you're not going to find a common thread that links these people because there actually isn't one. So
Mhm.
I think that's actually a major problem as to why people have found the EDS hypermobility type such a difficult, connective tissue disorder to pin down genetically, um, because the diagnosis is actually too wide. So
Well,
I think that's
the genetic forms that are clearly associated with genotypes, with genes that we can identify, are pretty rare. They're in 1 to 20,000 people, up to 1 to 100,000 people. And a lot of them you can identify very early in life. Some of them are serious. The vascular form of EDS can be very serious. It can cause rupture of arteries. I mean, be life-threatening. But these are extremely rare.
Mhm.
And that's not what we're talking about in the hypermobility subtype. And I think people really, need to understand that.
Mhm.
absolutely. When you look at Ehlers-Danlos online, typically the summary is going to include all the various different types of EDS that you can have. And for not 1 minute am I diminishing the medical implications of having vascular EDS. You know, that is a completely different condition to
Mhm.
it really actually shouldn't even have the same name. It is a completely different condition to
Yeah.
what we're describing here. You know, what I have is, in my mind, I know it doesn't, for some people listening, they might find this actually offensive, but I'm going to use the word
Mhm.
anyway. I consider myself to have a benign form of
Mhm.
connective tissue disorder.
Sure.
Um, and I consider myself very lucky for that to be the case. Um,
But I think
but
that's an
yes,
important point, and I think the reason you're saying that is because there are all these different types that are the 13 different subtypes that are very, very rare, and some of them have really severe medical implications that can affect the heart and vasculature and, different parts of the body in that way, in a very medically severe way. And that's really important for people to know and for, our medical system to attend to them for sure.
But what
absolutely.
and when the genetics are negative, then we're in a totally different category. And when the body is, normal other than hypermobility, we're in a totally different category. And even the hypermobility subtype, if you look back 10 years or so, 15 years, the estimates were it was 1 in 5,000 people, right? 1 in 5,000 people, which is still relatively rare. And
Hmm.
now, and you mentioned Gigi, now when you look at how many people are being diagnosed with hypermobility EDS, we're talking about some studies in college students, 20%, 30%, 35%, more in women than men, 35% of women, 12 to 15% of men being diagnosed with this condition. This is a huge, how can a genetic condition become more common, like by a factor of 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 I don't know what the number is. It's like more than a factor of 1,000. I mean, it's just a
Yeah.
huge increase. It just makes no sense, man.
And I think so the categories are the 13 EDS variants that can be genetically tested that are very, very rare. And then there's the EDS hypermobility variant. that there isn't a genetic test for, and that's the one that you have more or
Correct.
less. Yeah,
Correct.
right.
So that's, I mean, who knows what category I'll be put in 20 years' time, because I have no doubt that, like I said, there were genetic signatures of me having something,
Yeah,
but
yeah,
it didn't fit into a category of another Ehlers-Danlos
yeah.
variant category. So at that point, I was given the hypermobility type, and I think that's why the original statistics made it sound like Ehlers-Danlos was the hypermobility type was much more rare, because the sort of process that you had to go through to receive that diagnosis was much more similar to the one that I went through. Whereas
Mhm.
now it's based on a series of, I mean, you can do a hypermobility test if you're
Sure.
hypermobile and, one finger, often it's overextension of your elbow. You might have a narrow palate. You might have, a slightly concave chest. I mean, I've got all of all of those. But it's a lot. I've actually seen clients of mine who, simply because they were hypermobile and in pain, they received an official EDS diagnosis, which in my mind, I mean, that's not even using the official
Yeah.
Yeah.
criteria
Well, there's
adequately.
another yeah, well, there's also kind of another category now, the hypermobility spectrum disorder. And in order to be diagnosed with that, yeah, it's just clinical. There's no test. And it's just that you're hypermobile someplace in your body. You don't even need to be generalized hypermobility and have other symptoms, including chronic pain. And that's all that's needed to make that diagnosis of hypermobility spectrum disorder. And certainly there's no genetic test or anything. And so I think that's a lot of what's led to so many people getting the diagnosis, getting their chronic pain attributed to the hypermobility, and then being called that they have this sort of disorder or syndrome that then is being used to explain all of these different symptoms like IBS or, GI dysmotility, anxiety, depression, insomnia,
POTS,
headache, POTS.
interstitial cystitis, all these
Yeah,
things.
dysautonomia, like all of these different
Yeah.
symptoms now are being attributed to the hypermobility state. But again, really coming back to how does that make sense that hypermobility in their joints would lead to this whole cascade of symptoms?
And doctors who don't have answers, people are coming with pain and other symptoms. They see, oh, these things are all connected, so let's put them into this category. And the amount of the attention paid to the hypermobility is variable, and one of the things I say is that if you do very clear testing for hypermobility, you may find it or you may not find it. In either case, you're going to say, well, it's still hypermobile Ehlers-Danlos, in
Yeah.
which case you're now laying that on somebody with all the negative expectations and all the stuff that you went through that we're seeing more and more people go through. And the fact is that there are 4 separate studies in college students where they took people and took just a bunch of college students, hundreds of college students, and they examined them for hypermobility, and they find that a lot of people are hypermobile.
It's 1 in 5, I
Right?
think.
Yeah, up to 20%. Some studies are 36%. Again, more
Mhm.
in females than the men. But when they look at does pain vary? Do the people who are more hypermobile, are they more likely to have pain than the people who are not hypermobile? And the answer in each one of those studies is no. There is no correlation between, this is so powerful data. 4
Mhm.
separate studies, there's no correlation between people who have hypermobility and if they have pain or not. And
Mhm.
so
Absolutely.
how can we just blithely make these assumptions, as Becca was saying, that, oh, because you have pain, you're maybe a little hypermobile, maybe you aren't. Still, we'll just call it EDS because we don't know what else to call it.
Mhm.
Absolutely. And I sometimes laugh because I think, I mean, anecdotally, how many times has a doctor recommended that people stretch for good physical health to improve their flexibility?
Yeah.
We're actively encouraged to try and become more flexible. And then suddenly the thing that we're encouraged to do or to be becomes the villain of the story, and it's, oh no, you've overshot it, now you're too flexible. It simply doesn't make any logical sense. And I think sometimes we try and fit explanations in it that don't actually make any logical sense, and we're just doing it to try and provide an answer rather than it being the right answer, because it's almost an answer. Becca, to go back to what you said before, a patient wants a diagnosis, so an answer is almost better than no answer, except for, is it really in the long run?
Right.
Yeah, right. I went to medical school 25 years ago and learned about EDS, that, this was really rare genetic condition, never mentioned anything about pain. And then about 10 years ago or so, I just started seeing all these people diagnosed with hypermobility and diagnosed by rheumatologists in hypermobility. And I was so confused, I have to say. And again, clinically looking at what my experience was as a primary care doctor, is I would, just like you were saying, like I would see people that had just pelvic pain, and that was it, didn't have other symptoms, and that was being blamed on their hypomobility, and sort of given a story that, well, the ligaments were so lax and that was what was going on. Well, again, how does that make sense if it's genetic and they didn't have any problems for 4 decades, and then now it's starting, but it's just in this specific spot in their body? How does that make sense? I also had patients that the same thing was told about GI dysmotility, that somehow the structures in there, because they were too loose, was causing the symptoms. Again, how does that make sense that it's starting 3-4 decades into having this, when the hypermobility actually goes down as you get older?
And I would say the same for cervical instability. That's something that I hear a lot now, and that as an explanation can induce such a level of panic in people,
Right.
And what I find interesting is, I've seen this in a number of clients, the moment they're told about cervical instability, they may not have experienced dizziness prior, but dizziness is often something that really follows shortly after being told that you may have cervical instability. And it's such a powerful example of expectation then influencing our reality.
Absolutely.
And I just have to say, the doctors, they're just, with all these, diagnoses they're putting into the Ehlers-Danlos camp, they're just really stretching it.
Yeah.
That was a joke. That's a joke.
You have to warn it.
When I have to explain my jokes, this is really bad. Get it?
Funny
Stretch.
jokes, you don't have to warn us. But the other ones, let us know.
Okay. Sorry. We can edit that
I was prepared. I was prepared for everything to become looser. I was prepared for that one.
I came up with a different one.
A dangerous
game.
It
is, the old diagnosis, back when I trained, it was fibromyalgia. That was the diagnosis. That was, everybody had that diagnosis and had this whole constellation of symptoms. But then, people don't have the diagnosis of fibromyalgia so much anymore as, back when I trained. And now people have hypermobility all over the place. And it's really replaced, I think, the diagnosis of fibromyalgia in many ways.
Totally. And I think one thing that I will say to anybody who's listening who really strongly believes that they have a connective tissue disorder, and you don't want to let go of the Ehlers-Danlos label, in the same way that I still consider myself to have Ehlers-Danlos, that does not, I can't say this more clearly, that does not destine you to a life of constant suffering. And that's why I'm genuinely very keen on research being done into genetic predispositions of traits and personality, because I think that is far, far more relevant in explaining somebody's symptom experience than trying to attribute everything to a pathological or physiological problem. In my mind, there is absolutely no evidence to suggest that the neuroplastic symptoms that people with Ehlers-Danlos are experiencing are as a result of hypermobility. It's illogical and it should be discarded. If you're really following the scientific method, it's not wrong to have a theory, but when the evidence does not match that theory, you gotta let it go. And same, we have to apply that here. Whereas I've seen on many occasions people, when they describe how they feel in the world, when they describe, I struggle to have a conversation with somebody with background noise, because I just keep focusing my attention on what other people around me are saying versus the conversation in front of me. That I find more interesting, because that's how their brain is actually processing information. Now, if
Yeah.
their brain is much more likely, or if one's brain is less able to filter out information, you are naturally more likely to experience overwhelm. So that can then lead into the development of a
Yeah.
condition. So
Mhm.
that is a much more interesting area of research for me in the Ehlers-Danlos camp than something
Yeah.
Well,
physiological.
I don't know if this would be a compliment to you or not, Gigi, but you are extremely flexible. And
Yes.
I think you're flexible in your joints, but I also think you're flexible in your mind and your thinking, your
Oh,
thought
thank you.
process.
Thanks. Well, I think
Maybe that goes together. I don't know.
yeah, exactly. Maybe that's the link that we have to
There you
understand.
go.
No, it's I think you're forced to be flexible when you feel like you haven't got the answers, that nothing seems to be making sense. You're forced to think outside of the box. And one thing I'll say, not to give myself any credit at all, I am amazed that this is now what I do. This is, in terms of my personality type, I am absolutely the person who will assume something is physiologically wrong versus, something emotionally going on. I wish that when I had discovered this work, I had been open-minded enough to accept it and to say, this makes sense. I could see how this could happen. But I can't give myself that credit, because that honestly wasn't the truth. I found it incredibly insulting. I thought, no one understands what I'm going through if they're saying, that this is brain derived, and I'm feeling these symptoms in my body. I was neglecting the the fact that even when you break your ankle, it's still your brain that produces the symptoms. So I was neglecting that. But
They didn't
I've
teach you that at Oxford?
I'm sure they did, and I'm sure that was something that went in one ear and out and out the other. But I think when you're in a state of panic, the basic facts can often, your ability to think about things rationally or logically just goes out the window. And so, I
Yeah.
think that's what was so powerful about reading your book, Howard. Is I think that was one of my first, I had several sort of resets, I think, that helped me to see things for what they were. That was definitely one of them. The other one relates specifically to my IC symptoms, but at the time, and still now, there was a theory that IC is caused by an embedded infection. And I think many people, really, including myself, really liked that as a theory, because I felt that it took my symptom experience seriously, and it sort of mirrored what I was physically experiencing. But one of the things that happened is I was on antibiotics. And by the time I started taking them, I was so desperate. I mean, I can't describe emotionally how low my mental health was. I didn't foresee that there would be a life that I could live. I mean, it was really out of pure desperation. And when I took it, I think there was such a relief in giving the power over to something external that
Yeah.
I let go. I must have let go in that moment, even just a fraction. And my symptoms, in the space of 3-4 hours, went from, I know it sounds hyperbolic, but genuinely what felt like a 15 out of 10. I couldn't speak, I was in so much pain, to around a 4 out of 10 in the space of a couple of hours. And that was another one of those moments where I thought, well, I know antibiotics don't work that quickly. But it was funny, because even then I was still a bit blinded. I thought, well, I don't really mind if they don't work that quickly. They're still working. So I then took them for 3-4 days. And on the 4th day of that period when I was on antibiotics, because I had been on it before, but on the 4th day of being on antibiotics, my symptoms started coming back. And
Mm.
that's where I really was forced to face the reality of what was going on, because it's impossible that I could have the fastest reaction known to man, that the bacteria that I had was the most receptive to antibiotics. And then in 4 days, they became completely resistant to it. That didn't make any logical sense either. So I think when what I always encourage with everybody I work with to do is just build up the pieces. You may never have a eureka aha moment where suddenly it all makes sense. But the one thing we can be certain of is when something is neuroplastic, you will continue to get evidence that it's neuroplastic forever because that's what it is. And so if you're prepared to pick up those snippets of evidence as time goes on, you will ultimately build a case that could convince any jury that this is what it is, and you just have to give yourself that chance and be willing to give yourself that chance.
Yeah, that is
Very
such a
well
good
said.
point. Yeah, for sure. I have one last question for you,
Mm.
Gigi, is
Yes.
I've had patients say who have hypermobility that the reason that people with hypermobility get chronic pain is because of the proprioception, because their joints are moving around and they don't know where they are in space so much because they're not more firmly set, that their brain learns to become hypervigilant just because their joints are moving more than someone's joints who isn't someone's joints who's not hypermobile would move.
I think I have two answers to that. One is that's as an argument, it's a point that we made earlier. We are the most hypermobile when we're younger, and we become progressively less hypermobile as we get older. So if that were the case, our symptom experience would follow that, and that doesn't
Yeah,
happen. And the
yeah,
other thing that I would say is when it comes to anything structural, the brain is designed to produce warning signals when there is something out of the norm. Now, hypermobility, when you're really hypermobile, hypermobility is the norm. Things moving around.
Sandy, that is your norm. How does that person's brain know what someone else's joints do?
Exactly that. So your brain is adapted to receiving the information that it typically receives. And
Yeah,
that
right,
becomes the background. So it
right.
doesn't matter. I say this, talking to people about how the brain adapts to anything. When you first put on a pair of jeans, you feel those pair of jeans, right? But
Yeah,
over
right.
time, the experience becomes invisible because it becomes the normal, right?
Yeah, right.
The same is true with the sensory information coming up to us from our body. That is your normal. It is the standard. There is nothing to warn you about. And your brain is not designed to warn you about the normal, right? There's no
Right.
Yeah,
benefit to
yeah,
doing that.
That's
yeah.
really important. But I think what they're experiencing, that hypervigilance, is there. It's real. They are experiencing that hypervigilance, but it's not because their joints are overly mobile or flexible. It's because they've been told that their joints are in danger. They've been told that they can have a fracture at any moment. They can have a dislocation at any moment. So that hypervigilance builds and builds and
Mhm.
builds because of the fear of hypermobile Ehlers-Danlos syndrome.
Absolutely.
Mhm.
And you can learn that anything is dangerous. You could learn that a door in a house is dangerous, right?
Yeah,
Yeah,
And
right.
every
yeah,
time you see that, you could then feel a fear response. So if you're told by a doctor this is what's happening, it's the flexibility that's now dangerous, your brain the way your brain responds to that changes. So it learns what it previously perceived as normal now
mm,
becomes in your brain's mind abnormal, right? So then it becomes a self-fulfilling prophecy
yeah,
where
Yeah,
that
exactly.
flexibility does in fact become the reason for your pain, but not because it has to be the cause of
yeah,
your pain.
yeah. Absolutely.
You have been a
Amazing.
fantastic guest,
Oh, so
Oh, thank
Gigi.
you.
amazing. Yes.
Thank you
Amazing. Thanks
so
for
much.
sharing your story. Yeah.
Oh, of course, of course, of course. I really, really hope that anyone listening to this, whether you relate to the Ehlers-Danlos side of my story, which obviously we focused on more today, or the chronic fatigue side, or the chronic pain side, or the IC side, or the egg cracking side, no,
A
no
lot to
matter what
choose
it
from.
is. Yeah, a lot to choose from. And I always forget ones. Oh, I forgot, my IBS. I always forget things that I went through. But
Yeah.
regardless of what part you relate to, you can become 100% symptom free, really, truly. And that never, ever changes.
Awesome. Amazing. Well, thanks so much, Gigi. Really, really nice to have you on. And thank you, everybody, for joining us. We look forward to seeing you next time.
Aren't you
And
going to
this
say
is
I'm Becca Kennedy?
I'm Becca Kennedy.
And I'm Howard Schubiner.
And this is The Science Behind the Symptoms. We'll see you next time.